leading on to the activation of all these nuclei. And if you see, there are about 50 nuclei in the hypothalamus that can be triggered by various mechanisms, including fasting, including menstruation, including stress, including sunlight exposure, and all known triggers of migraine. So we don't know the details of which one actually is causing what, but we do know that these are the areas in the hypothalamus. They are deeply connected with these brainstem symptoms, brainstem regions to produce the symptoms and the triggering of migraine. So this is one of the group which believes that the migraine generator is in the central nervous system, and this brain gets activated. Because why would a person who is otherwise normal will suddenly, in this meeting, with a simple light going on, will start having this throbbing headache after, half an hour or so? Why does this happen? So probably it is because of this, activation of the dural vessels and leading on to the changes as I described. And then they actually constructed the ascending pathway, and individually went on to examine the trigeminal ganglion, the spinal part of the trigeminal, and the entire pathway to see how the sensitization is happening. Now, in clinical terms, the sensitization means that when you have a repetitive stimuli, then with sensitization what happens, that you need a lesser strength, but you get a greater response and more frequent responses if the neurons are sensitized. So what they did is that in the rat model, they have a trigeminal ganglion recording, and they have also had a MRI recording, and they showed that actually during the throbbing phase of the headache, there is the sensitization of the trigeminal ganglion. And you can see in the lower cut, this is the before the the headache is induced, and this is after the headache is induced. The amplitude is markedly increased, and this is the evidence for sensitization, and that is also shown up in fMRI. So basically, what they are saying is that the throbbing pain, which was earlier considered to be vascular in origin, the vessels are contracting, going like this, because the throbbing nature is no longer because of vascular pathology, is because of a neural pacemaker, neural sensitization, which is causing the throbbing pain, and also the pain. While migraine patients will not like to move their heads during a severe attack. So because it's motion sensitivity, this is also because of this neural pacemaker. So this was actually now taken care of by this famous study, in which they have done actually the magnetic resonance angiography of intercranial and extracranial arteries in patients with spontaneous migraine without aura. And they found that the migraine pain was not accompanied by extracranial arterial dilatation and only by slight intracranial dilatation. So the vascular theory has gone off, and I still see prescriptions being written as vascular headache. So please do not write as a vascular headache. Migraine is not a vascular headache, it's a headache because of the brain matter, and it's in the realm of neurology. Okay, now you must have heard by late 20th and early decade of the century, the people were talking about the brainstem generator, because when they actually filmed the fMRI during the acute attack, they could find that these areas are dorsal pons is lighted up. As I said, that because of the RNMI study, there is a functional connectivity issue with the dorsal pons. So that is again taken care of by explaining a beautiful paper by again the Bernstein from Harvard, is that brainstem also, you have to realize that there is a cyclical activity of the brainstem. It is not a static thing, right? So if the cyclical brainstem activity is high, the threshold is increased for transmission of nociceptive, and therefore the nociceptive impulses are inhibited. But if it is low, then the threshold is lower, and actually it's like almost like a gate opening and gate closing. So this is a diagrammatic representation they are giving, and you can see that depending on the cyclical activity of the brainstem, actually some of the same triggers are going to cause in some persons sometimes the attacks, whereas the same triggers will not cause the attacks in a similar situation. So that explains. But in the diagram you can also see that there is an arrow downwards, which is talking about a balance between the ascending information and the descending pathway that is going on. So what is this brainstem brain regulatory or modulatory circuitry? Now this is, this actually was discovered because people were researching on opioids, right? Why do the opioids act? What is the endogenous analgesia system in the body? And when they found out that there is a very significant descending pain modulating system which is originating from the back, the paraqueductal gray, to the rostral ventral nucleus of at the medulla, RVM. So this axis, the back RVM axis, is very, very important for this descending pathway, and also it has got connections with the spinal fifth, and as well as there is a particular group of cells called SRD, the reticular dorsalis neurons. They are important in entire regulation of the pain pathway which is descending down. And it's a balance between the ascending pathway and the descending pathway that depends on how much we are perceiving the pain. And people have identified that there are neurons in the RVM which are called on neurons and off neurons, and they can actually get on and off, and that because of that your entire perception of the pain, the endogenous perception of the pain, may vary depending on a lot of sociological, physiological conditions. Like for example, you know that when you are actually a soldier, for example, when it's fighting in the war, even if he has got a great injury, he is not able to feel that pain. Why is it so? It is because the brain has got certain capacity of analgesia by itself. So because of this, there is a physiological concept in the experimental medicine, in the rat models, in the models of dogs and cats, that this is known as a diffuse noxious inhibitory control, DINIC. It is a descending pain modulatory system, just I showed you, recruited by distant noxious stimulus that can suppress firing of convergent second order sensory neurons. The human counterpart nowadays is called the conditioned pain modulation, CPM, the psychophysical outcome of activating the DINIC. So this is the experimental one and this is the human one. And there is evidence that in humans this may play an important role. How? The noxious stimuli activates the endings of the nociceptive C and A delta nerve fibers which carry the signals to the neurons of the dorsal and the spinal cord. This we have seen. And whenever you have a stimulation from one location of the body that might be inhibited by the noxious stimulus such as heat, high pressure, electric stimulation applied to another remote location of the body. And this inhibition is thought to originate in the brain and because of this descending system. So you see that there is an ascending system, there is a descending system, and their balance is very important. If you go to the dorsal horn circuitry, you see that in anatomy you must have heard about the rexate laminae, laminae 2, the substantia gelatinosa. But if you see in dorsal horn circuitry, it is very complex. It is highly complex circuitry. And there are neurons called wide dynamic range neurons, WDR, and they are capable of actually getting involved in this descending pain modulation, where there are other nociceptive, and they have different chemicals, the peptides, peptidergic systems, GABA systems. So there is a balance between the excitatory and inhibitory systems, and that can modulate the pain perception as we can feel. So about the early part of this 2010 or so, this was a early paper on neuromodulation. Here you see that obviously they could target the neuromodulation, think of neuromodulation. They were thinking mostly in terms of the descending pathways, right? They had a cortical, you can target the cortex, you can target the deep brain, you can target the occipital nerve, vagus, and sphenopalatine ganglion, and the supraparietal. But what has happened with this increasing understanding of this descending pathway, now we have a device which will be talking about, is basically conditioned on this conditioned pain modulation, the CPM. Now, before I go to that, I will say that I'll give you a list of the gadgets that are available. Some of you might have used Safari. It has been in place for a long time now. Of course, now I think the availability is an issue. This is in the front, targeting the supraorbital nerves. This is the second one, is called Relivion. It is targeting both the front and the back. And then there are modifications of the Safari device that are also coming in place. Then you have got a small mastoid tip stimulator. Then you have a gamma core, the vagal nerve stimulator, handheld device. Then you have got an oral auricular nerve stimulator, again the vagal nerve stimulator, auricular device. And then you have got the REN device. Then you have got the single pulse magnetic stimulator. And of course, this is again is coming in a big way is a direct transcranial stimulator. But a lot of studies need to be done on that. So among these, the TIC ones are got the FDA approval, both for episodic and some of them for acute attack as well as for the prevention. So let us first go up the cephaly. This was approved way back in 2014, followed by 17 and multiple other indications. Initially for the prevention, then later for the acute treatment. The second generation model has come up. There's both acute model, prevent model, and dual models are available. And basically, you have to give a 1 hour session, and for the high impulse for the acute model, and for the prevent model, you have to give daily about 20-minute session at a low impulse frequency. So the putative mechanisms here is the targeting the gate control. You know the Belzac and Wall gate control theory, that you have got A beta fibers and you have got the C and L delta fibers. One opposes other, and there are interneurons which can cause and can make the pain subside depending on the stimulation of either of these systems. So it is still considered to be this was developed in Belgium actually by the Schoenen group, and initially they presented a paper, kind of a poster in which called the premise trial, in which they could show that there was some degree of response, and 50% responder rate was good for the active device compared to the sham. And then the major trial was this, the ACME trial, which was again a good trial, and that shows that actually there is a decrease in the pain intensity as well as the relative change in the VAS scores, leading towards FDA approval for the acute treatment of migraine. Right. Now, this combined neurostimulation, and I think this makes sense because obviously when you actually want to target the pain system, you can go on. If you just concentrate on the trigeminal in the front, you will lose out, because as I showed that there are back connections. So therefore, it will be important to target the greater occipital as well. And so you have got Levion and this thing, but the trials are far and few, and so it is still not certain that how much will be the efficacy. I don't have a data for that. There is one study from the Turkish group in which they have shown that even in an emergency setting, a thing which is almost like a cephaly device they have used, and they have found that in emergency setting also that the 10 therapies are useful. The adverse effects are minimal, but of course you cannot give it in the patients who have got certain other electronic devices in the head for the trigeminal neuralgia or ophthalmic shingles. You cannot give in patients who are having pacemakers, right? Now this is again a thing this has come from initially from an Asian group, but it has not again seen the light of the day. I think it has got a very limited availability, but they do have a randomized trial, and this is for prevention, and this is called the mastoid stimulator. The main change was this gamma code, right? This was considered to be very promising and good, and at least initially tried with a very severe form of headache called cluster headache, and then later on shifted to the migraine scenario. Now you have got this stimulator. You have to fill with a cartridge, and you can give multiple stimulations. Then the stimulation paradigms are different. For example, for acute migraine, you can have at the start of the pain 3 2-minute stimulations, then 20-minute wait, and then if the pain remains again, and you can give maximum 3 such treatments to relieve the acute migraine attacks. For adjunctive treatment of cluster, you can give it in the morning, in the evening, night, again 3 2-minute stimulations. And for acute cluster headache, you can give at the start of the headache, and you can give again after 3-minute wait, you can give after again a 2-minute stimulation. So I have used it only in cluster headache patients. I got it from UK. The machine is costing with the tax and all, it cost about $50,000. And the problem is that there is a monthly refill, but the cluster headache patients are so desperate that they are, especially the chronic cluster ones, So one of my patients who uses the doctor. So it is useful, but in migraine again, the data is there, but it is not very robust. There are multiple mechanistic pathways that have been described. All are conjectural. We don't know yet. But obviously, because as I said that there is a parasympathetic initiation at the level, so vagus nerve modulation might be helpful from that point of view. So these are the studies. For the top are the cluster headache, and the later one are the migraine. And we can see that for the cluster there is a very good response. P values are highly significant, and the therapeutic gain is significant, about 25%, 40%. But for migraine, it is not so good, and only on the modified intensity to treat analysis, when they did it, they found it as a P value significant, and the therapeutic gain was not significant. So therefore, there is a questionable. But I have advised one of my patients in Dubai. She's a pregnant. At that time, the REN device was not available, so she has got it, and she has got some relief with this, where they don't want to use medicine. Now again, the side effects are very minimal, and usually the application, because once you start increasing the strength of the stimulation, then you start having slight flickering of the muscles of the face and the eyes. So that's problematic for some patients, and that may cause irritation and redness. Now these are the auricular. This is again an European group. They have started manufacturing it, but I don't know the availability, and there are no randomized trials that are available. But apparently it looks attractive, at least by seeing the diagram, right? By seeing the photographs. Now we come to the actual thing, the Nerivio, for which this has been now recently introduced in India, and therefore this is one device which is available to you, and I think you should know about this. So it was originally developed by in Israel by Israeli company, and then it got the FDA clearance in 2019 for patients of episodic migraine without aura for 18 years and older. So the device is applied in the upper arm, right? And then it is controlled by a Nerivio app, which is for iPhone and Android, both are available, which is downloadable from the App Store, right? Now, so this is again, as I said, that this is entirely based on this concept of the central pain modulation, which is that they are targeting the descending pathway. And so what is the point is that when you give a conditioning stimulus, which is also known as heterotropic counter stimulus, you actually inhibit the incoming pain stimulus which are generated during the migraine headache. So that is in principle, and that is because that this is actually causing a facilitation of the CPM, and therefore causing a relative analgesia. So the body is taking care of this. Actually, this work has been largely due to a pioneering work by this person called Professor David Yarnitsky. He is from Israel, from Hapia University, and he has done a lot of basic work in pain medicine, and later on he was interested in the CPM, and then the initial trials were also conducted by him. But then there are other evidences as well that we could find, in some of the studies, that in migraine headaches, there is a deficiency of this conditioned pain modulation, and therefore if you can somehow enhance this, that migraine pain may actually respond and may become better. So this is one article. There is another article, very interesting article. This is published last year in 2022. So once you stimulate in an artificial setting by using a thermode, by giving a thermal sensation to these patients, and in the 4 groups, control groups, interictal migraine patients, and immediately prior to migraine, you see different activation patterns in the brainstem. And even as you can see, the RBM, the ipsilateral dorsolateral pons, contralateral dorsolateral pons, and the back, they behave in a different manner. And this all suggests that there is an active descending system which is probably deficient in migraineurs, and just before the attack, probably they become active, and if you give this stimulus, then probably you will be able to activate this. And therefore, this entire concept of this machine or the gadget, where you have, as I said, that if you can actually target this descending inhibition pathway and make it more compliant then probably the migraine headache will go off. Now, as for the evidence, there are a lot of trials that has happened with this device, because I think the main attraction was the ease of use. You know, you just have to wear a band, and that's all, and then you can easily modify and manipulate with a smartphone. So this was the first, and this is by Janitsky's trial. So they have about 100 patients each in group, the REN group and the sham group, and the device was applied for 45 minutes, right, in the lateral upper arm, regardless of the headache. If it's a unilateral, it doesn't matter that you have to do an opposite side, regardless of that, but it has to be started within 1 hour of headache onset, right? As soon as possible, the headache starts, and then there is a defined frequency, pulse width, and the current, and there is a basal level which is set up in the machine, that is I think 20%, and then you can increase depending on your need and how you feel, how uncomfortable the sensations are. So it should not be painful, but it should be significant enough to produce that conditioning stimulus. So what they found is that, you know, in acute trial, there are various measures to measure the outcome. One measure is, of course, the pain freedom, that the patient gets totally devoid of the pain within 2 hours, right? One is called a pain decrease. It is not completely gone. Pain relief by 2 hours. Then there is also nowadays, most of the acute medication trial include another endpoint which is known as the most bothersome symptom, that is the MBS. Now, you know, migraine patients may not only have pain, they have significant nausea, they may have significant photophobia, phonophobia. So these are also important. Some of the patients, the headache might be not that much issue as this other most bothersome symptoms. So it is to be seen that whether your acute drug or acute intervention also gives release to these most bothersome symptoms. And then you have got another measure which is called consistency in effect. Like if the patient is having 5 attacks, you have given and treated with the intervention 5 times, and how many times the patient has responded to that. So if it is a consistent effort across the attacks, then it's a good drug. So they have studied all this, and they have found that, you know, for the pain relief, it's about 28%. For the pain free, it's about 19%. And for the MBS release, it's about 25%. So what does it mean, actually? It means that, you know, in most of the trials of the acute medications, in neuromodulation, this has been around to the tune of about 12 to 20%. That if you use this gadget, that 1 in 5 patients will be off their headaches within 2 hours, right? That is what it means. And the therapeutic gain is about 20%, so they will not get completely off the headache, but they'll get better. And this is slightly dubious and slightly less objective, but, you know, 50% decrease or, you know, significant decrease in the headache, effect intensity. And as I said, the sustained pain response also was good for this, and within subject consistency was also very good. So overall, because of this result, and that is 2 hours pain relief and the 48 hours post-treatment. So overall, this kind of results were good, and they got the approval because the side effects were very minimal, 5%, and they're mostly mild, and they were not causing much problem to the patients. The continuation rate with the device was very good, and so they got the FDA approval. Subsequent to the approval, Alan Rappaport did a study, and in which they actually, compared the people who are receiving acute migraine and with this device and the usual care, and with the concomitant use of preventive medications. They were also on preventive medications. So what happens that if you give preventive medications and if your acute attacks keep on happening, then sometimes the preventive medications also fail. They no longer become effective. So what you found out that in fact, compared to the acute running phase, the acute treatment and the REN, they were actually faring better. And also, they found that the preventive treatment use has no effect on the effectiveness of this gadget. So whether the patient is on preventive medication or not did not affect its outcome. So this was good because this actually provided an evidence in real life that you can have this gadget which will be probably as good as taking an acute medication, and therefore we recommend it in certain populations. Then there was a large, follow-up study, after the marketing part by Manura, which has been published, and they again found that achieving the pain response, at least 50% of the attacks was very high, about 70%, 77%, and pain-free rate was also very high. And actually, if you see that during the open label phase versus during the running phase, you have got a large dissociation, and 90% of the participants could avoid medication in all their attacks when they started using this device. So that was a good thing, because that showed that it works, and it might be helpful in not many patients. Now, although there is no direct head-to-head comparison between it and the oral drugs, but we know from the previous studies that what are the responder rates in there. And if you see that this device fares fairly well compared to the medication. Now remember that you see that this bar, the placebo bar, right? This is normally in all headache research, this is about 25 to 30%, right? But when you do an intervention, like you are using a device or you are using a very touted new agent, the placebo rate increases. It comes to about 40%, right? Because of the expectations of the people, right? Or you are doing something palpably with the patient, right? So you have to see from this that you get a good response, but your placebo response is also high. And of course, there are problems with the oral drugs. We have the triptans as the standard of care and NSAIDs. And compared to that, here, of course, the side effects will be lower because it is not actually intervening in any other way with the other body systems, right? Now, there is a recent trial for the prevention of migraine, which is published by Stu Tepper. And again, there are about 100 odd patients in each group. And they also showed that at least there is a significant decrease in the mean migraine days, at least statistically, in terms of patients as a preventive therapy of migraine. And they have compared it with other studies. But I find it that you need to, and in this group, what they did is that they give alternative day therapy. Like not every day the patient was using the REN. On alternate days, the patients were using the REN device. And so they have found that the 50% reduction in moderate to severe headache, again significant compared to the sham, and also the reducing the headache days and medication intake, the total acute medication intake, that was also significantly favoring the device. So safety analysis again for a long-term use is also good. It really doesn't really change, and it can be actually recommended. Although I think that more data needs to be given for a preventive aspect of this drug. Now, the chronic migraine people are very, very difficult people. They are very, very difficult subjects. Most of them are having medication overuse headache associated with them. And in them also they have found a preliminary analysis of 91 patients that there is a kind of a pain relief. But again, as I said, that this is again an open level kind of a thing. So therefore we need to be cautious and we need to interpret this. But then there is a large database of the patients who have been using this. And this is, about 12,000 plus patients with more than 1 lakh treatments that are available. And again, the more important thing for me is that overall the pain relief percentage has increased to some extent rather than decreased in the open label phase. And the pain freedom has also escalated from about 18 to 19% to about 23%. So I think given by this analysis, and if this is true, of course this is mostly from the population which might not be similar to ours, but I think that this holds a promise that it will be effective in a larger population. And another important thing is the pregnancy. So this is one gadget where there is a separate data available for about pregnant patients or 90 within a particular period of time, and they found that the gestational age didn't differ between those who used the drug gadget and the control group, and also the various other parameters like newborn birth defect rate, developmental milestones, miscarriage, etc. They also did not differ. So you can reasonably conclude that this gadget will be useful during pregnancy, and therefore, because most of the drugs are contraindicated in pregnancy, but migraine patients normally have when they get pregnant, their migraines go down, right? But about 30% of them actually remain the same or may have an escalation. I had recently a doctor a neurologist. So she was, she didn't want to take any medication. She had to go and attend an international conference, and she was much disturbed. And when I actually advocated her this, and she took it, and she got much better. So, of course, after a while I had to give her a block also, one block also. But she did benefit from this device. So, what are the possible scenarios for Derivio use from Indian context, right? So, of course, it's pregnancy. This is one thing which you can use in pregnancy pretty safely, and it will be useful. Patients looking for medication-free treatment, they don't want the medication. Intolerant to migraine medications, a lot of patients are intolerant. We have to ask them to find out, right? Contraindicated or comorbid patients where, for example, in CKD patients, where you cannot give analgesics, probably they have uncontrolled hypertension, you cannot give triptan. So there it might be useful. A lot of CKD patients have migraine, right? So you need to give something for them. Then adolescent, young onset migraine, because they don't want to use drugs, they are athletic, they want to do active work, they might be requiring this kind of, they will prefer this gadget. Medication overuse is obviously, this is an important thing. Women with childbearing age, as a sweeping statement, we don't know that maybe that some, if it proves to be useful on a longer run, then probably the young women who come to you in the OPD with a childbearing potential, and you can tell them that, okay, fine, this is an option you can take, it will be harmless. Menstrual migraine, I don't know there are no studies, but it gives a kind of a window, because menstrual migraine are two types. One is exclusive headache, migraine headaches, which happens exclusively in the perimenstrual, at the start of the menstrual cycle, or in migraine patients, the migraine gets exacerbated during the menstrual cycle. So we have got transitional, acute treatments that are available now. For example, Provatriptan we can give, right? But we can also use this gadget, to tide over that period of migraine during the menstrual cycle. So that will be a possibility, but a trial needs to be done on that. Acute and chronic migraine, again, a general statement. Now, with the advent of so many drugs, and especially with the advent of the MAPs and the CGRP antagonists, which are also fairly safe, but of course the cost is a consideration, and many of them are not still available in India. So I think the case is still open that whether we can be using this or not. So to conclude, that many innovative headache devices based on principles of neuromodulation targeting various levels in the complex pathophysiology of headache and migraine in particular are now available. Now in India, I think these people, the Gamma Core, I'm talking to them, that they might also come in. So the routine incorporation into clinical practice will be dependent that when we start using them, they have a sustained efficacy and safety profiles, and of course cost effectiveness. Now this device which they are marketing now, the Derivio, for the 18 sessions, the charge is around 14,000, I think, which is available for 18 sessions. So I told them that that's still high, you need to cut down on the price. And of course, if you are prescribing for chronic migraine, obviously, then after what does that patient do after 18 sessions? Obviously, another 14,000, 15,000 is difficult. So cost is a barrier, of course, but I think in India now we are seeing a niche group of patients. The patients there are a lot of patients who have come to me. For example, one international airline pilot, he wants to get off his headaches before his flight. so 45 minutes before the flight, he puts the device, and if he gets off his headache, doesn't have to take any medicine. That's good. I have a dancer, very famous dancer. She every time she prepares for a stage show, before that, she fears that she'll have a migraine attack, so she has to take an acute medication before a performance. So maybe a device might help. So these are the special scenarios where and a lot of high-tech Indians who are doing a lot of shift duties, the managerial posts, executives and all that. They have a lot of migraine, and they might not be want to be drugged, don't want to be groggy, and there this device can be very useful. So this is in short the summary of neuromodulation for you with a little bit of pathophysiology. Thank you.